Pleural disease. Pleural diseases, pleural effusions, pleural malignancy, hemothorax. Pneumothorax. The mechanisms of pleural effusion: increased hydrostatic pressure, cardiac failure; decreased oncotic pressure, protein deficiency; decreased pleural cavity negative pressure, atelectasis; increased permeability and microvascular circulation, infections, inflammation; impaired lymphatic drainage of pleural space, tumor, fibrosis; transperitoneal route, congenital defects, ascites; chest pain, inspiratory. Symptoms: chest pain, inspiratory; decreases when the fluid increases; dyspnea; cough. Symptoms of the underlying disease: fever; hemoptysis; weight loss. Physical signs: no physical signs can be detected when the fluid is less than 300 milliliters. Increased size of the affected hemithorax. Ipsilateral restriction of chest wall motion. VT absent. Dullness, greater than 300 to 400 milliliters. Diminished breath sounds or inaudible. Pleural friction rub. Radiology. The fluid initially accumulates in the more dependent recesses of the thoracic cavity, forming a demoiselle line. 200 to 300 milliliters of pleural effusion can be detected on standard chest radiograph as blunting of the costophrenic angle. Massive pleural fluid often shifts the mediastinum to the opposite side. Accumulation of the fluid between the diaphragm and the interior surface of the lung, subpulmonic fluid. The hemidiaphragm appears to be elevated, widening the distance between the top of the gastric bubble and the top of the left hemidiaphragm, greater than 2 cm, and flattened. Blunting of the posterior costophrenic angle on the lateral chest radiograph, pleural effusion in a lateral decubitus radiograph. Smaller amounts of pleural fluid can be detected on lateral decubitus radiography as the free intrapleural fluid moves from top of the diaphragm to the dependent chest wall. Pleural effusion in a lateral decubitus radiograph. Unusual localized pleural effusions can be seen due to the localized obliteration of the pleural space, often by inflammatory conditions. Ultrasound is able to demonstrate smaller amounts of fluid as 100 milliliters. CT has similar sensitivity to ultrasound, not routine but can be performed to evaluate concomitant parenchymal lesions. CT is sensitive in identifying pleural thickening and calcification. Thoracentesis. Thoracentesis is indicated in all cases of pleural effusion of unknown origin. The site should be selected according to clinical examination. If the effusion is small, thoracentesis can be performed under ultrasound guidance. Thoracentesis is usually performed for diagnosis. Appearance of the fluid: serous, bloody, purulent. Biochemical, microbiological, cytological examination of the fluid. It can also be performed for the drainage of excess fluid, therapeutic, to relieve dyspnea. The amount of fluid should not exceed 1000 to 1500 cc at a time to avoid hemodynamic complications and re-expansion pulmonary edema. Pleural fluid analysis. Appearance: serous, light to dark, clear. Serosanguineous, blood-tinged, can be due to thoracentesis itself. Hemorrhagic, hemothorax if HCT 50% of blood HCT. Purulent, fetid odor and aerobic infections. Callous, milky. Biochemical evaluation. Exudative. Transudative. Some special hints. Microbiological evaluation. Cellular structure. Special stains and culture. Cytologic evaluation. Biochemical evaluation. Exudate. dark yellow color. Total protein greater than 3 grains/dl. Density greater than 1016. Light criteria. Protein PL/S greater than 0.5. LDH PL/S greater than 0.6. LDH greater than 200 or greater than 2/3 of normal upper value of serum. Transudate. Light yellow color. Total protein less than 3 grains/dl. Density less than 1016. Light criteria. Protein PL/S less than 0.5. LDH PL/S less than 0.6. LDH less than 200. Pleural cholesterol greater than 60 mg/dl, exudate. Albumin gradient. Serum albumin, pleural fluid albumin. Less than 1.2 grains/dl exudate. Greater than 1.2 grains/dl transudate. Pleural cholesterol greater than 60 mg/dl, exudate. PL/S bilirubin greater than 0.6, exudate. Microbiologic evaluation. RBC greater than 100,000/m3. Trauma. Pulmonary infarction. Malignancy. WBC greater than 1000/m3, exudate. Greater than 10,000/m3, emphysema, parapneumonic effusion, PNL predominates. Lymphocytes greater than 50%, tuberculosis, malignancy, lymphoma, fungus, myxedema. Gram staining. Zeal-Nielsen staining. Cultures for specific and non-specific infections. PCR. Transudative PL. F. Exudative PL. F. Increased hydrostatic pressure. Congestive heart failure. Constrictive pericarditis. Pericardial effusion. Pulmonary thromboemboli. Decreased oncotic pressure. Cirrhosis. Nephrotic syndrome. Malnutrition. Increased capillary permeability. Myxedema. Transperitoneal transport. Peritoneal dialysis. Ascites. Exudative PL. F. Infectious diseases. Pneumonia, lung abscess. Tuberculosis. Fungal infections. Subphrenic abscess. Neoplastic diseases. Metastatic. Mesothelioma. Lymphoma. Immunologic reactions. Dressler syndrome. Systemic lupus. Rheumatoid arthritis. Churg-Strauss syndrome. Wegener granulomatosis. Exudative PLF gastrointestinal disease drug-induced post-surgical. Pancreatitis. Causes of peritoneal exuda. Drug-induced. Nitrofurantoin. Dantrolene. Methosergide. Bromocriptine. Percarbazine. Amiodarone. Post-surgical. Pulmonary thromboembolism. Exudative PLF sarcoidosis, uremic pleuritis, asbestos exposure. Chylothorax. Hemothorax. Yellow nail syndrome, special characteristics, milky appearance. Chylothorax. Triglyceride greater than 110 mg/dl. PLTG/STG greater than 1. Cholesterol crystal, kilomicrons, plus. Sterile, bacteriostatic. Non-irritative, do not cause pleural thickening. AT, trauma, surgery, lymphoma. Pseudochylothorax. Triglyceride less than 50 mg/dl. PLTG/STG less than 1. Cholesterol 250 mg/dl. PLCH/SCH greater than 1. AT, RA, TBC. Emphysema. pH less than 7.20. Low glucose. Pneumothorax forms and chronic pleural effusions usually caused by tuberculosis or rheumatoid arthritis. Special characteristics: low glucose values, less than 60 mg/dl. Emphysema, complicated parapneumonic effusion. Tuberculosis. Rheumatoid arthritis. Malign effusions. Lupus pleuritis. Churg-Strauss syndrome. Less frequent. High amylase, over the upper limit of normal serum values. pH less than 7.20. Parapneumonic effusion, emphysema. Esophageal perforation. Rheumatoid arthritis. Tuberculosis. Malignancy. Pneumothorax. High amylase, over the upper limit of normal serum values. Esophageal perforation. Acute pancreatitis. Fistula and chronic pancreatitis. Adenocarcinoma, salivary amylase, eosinophilia greater than 10% of the total cells. Air or blood in the pleural space. Recurrent punctions. Pulmonary embolism. Benign asbestos effusions. Resolving pleural infections. Echinococcus infection. Loeffler syndrome. Hodgkin's lymphoma. Drug-induced pleural F. If the effusion is transudative, the main cause should be treated. If the effusion is exudative and not emphysema, further diagnostic procedures should be considered. Cytologic examination. Closed pleural needle biopsy. Thoracoscopy, VADS. Thoracotomy. Treatment of the specific cause, drainage of the excess fluid. Pleurodesis, performed to achieve fusion between visceral and parietal pleural layers. Main indications are malignant effusions, rarely recurrent benign effusions when other treatments have failed. After the removal of pleural fluid completely by thoracal tube, special sclerosing agents, tetracycline, doxycycline, bleomycin, talc etc., are injected to the pleural cavity. Surgical pleurectomy. Pleuroperitoneal shunt. Cardiac effusions. Predominantly caused by left ventricular failure, elevated pulmonary capillary pressure. Greater than 50% are bilateral effusions or 27% right-sided only. Usually the heart is enlarged on chest X-ray, phantom tumor, pseudotumor, can be present on the right side. Resolves with diuretics and treatment for left ventricular failure. Infectious pleurisy, emphysema. Bacterial pneumonia is associated with an effusion in 40% of cases. The effusion may be parapneumonic without infection, uncomplicated, or culture-positive, complicated, emphysema. Parapneumonic effusions are treated with appropriate antibiotics. Antibiotic treatment plus tube drainage is indicated if emphysema occurs. Tube drainage indications and complicated parapneumonic effusion. Purulent appearance. Gram staining, plus, for bacteria. Pleural fluid glucose less than 40 mg/dl. Pleural fluid pH less than 7.10 to 7.20. Pleural fluid LDH greater than 1000 IU/L. Tuberculosis pleurisy usually occurs soon after the primary infection and mainly affects children or teenager group. Pathogenetic mechanisms include direct invasion of AFB to pleura or delayed type hypersensitivity reaction. The onset of symptoms may be acute or subacute. Typical symptoms of pleural effusion and general symptoms of TB may be present. The affected population differs according to the prevalence of the disease in a population and the prevalence of AIDS or other immune-deficient conditions. Exudative effusion, lymphocyte predominance, low glucose, low mesothelial cells, less than 5%, high ADA tuberculin skin test can be, in 30%. Treatment, pulmonary TB treatment plus steroid. Other pleural diseases. Pneumothorax. Pleural fluid HTC 50% of serum. Can be traumatic or non-traumatic. Iatrogenic. Pulmonary infarction. Tumors. Rupture of aneurysm. Anticoagulant treatment. Thoracic endometriosis. Treatment. Intrapleural drainage. Thoracotomy. Colothorax. Direct passage of chyle from the thoracic duct into the pleural cavity. DG 110 mg/dl. Cause. Tumors, lymphoma. Trauma, surgery. Congenital defects. Lyme angioliomyomatosis. Tuberosclerosis. Treatment. Pleural drainage. Parenteral nutrition. Bed rest, to decrease lymphatic drainage. Surgical ligation of thoracic duct. Chemotherapy or RD. Fibrothorax, a thick fibrous tissue formed on visceral pleura cause. Empyema. Tuberculosis. Pneumothorax. Treatment, the cortication. Pneumothorax, PX. Presence of free air between the visceral and parietal pleura. Divided into 3. Open PX, penetrating trauma. Closed PX. Spontaneous, primary, secondary. Closed trauma. Iatrogenic. Tension PX, penetrating trauma. Physical examination. Hypersonority on percussion. Reduced breath sounds. Hypotension and cardiac tamponade may occur depending on the size of the pneumothorax. Radiology. Pleural line. Hyperlucency at the periphery. Mediastinal shift. Expiration film, lateral decubitus film can be used when the lesion is not apparent. Quantification of the size of the pneumothorax is helpful in the decision of treatment. Measurement of the average diameters of the collapsed lung and the affected hemithorax can be used. 183 113 100 equals %62. Greater than 2 cm pleural line from thoracic line inhaler region is large PX. Simple observation with rest and supplemental oxygen can be used for asymptomatic patients with a small, less than 20%, PX. Intercostal drainage is indicated in large or bilateral or tension PX. A recurrent spontaneous pneumothorax, 30 to 50% risk, is an indication for surgery. Smoking should be quitted after first attack. A patient with PX cannot travel by air until totally expanded in chest X-ray. Pleural neoplasms benign, malign, metastatic, pleural lipoma. Local pleural fibroma, fibrous mesothelioma. Malign. Diffuse malign mesothelioma. Metastatic. Bronchial carcinoma, adenocarcinoma. Lymphoma. Breast carcinoma. Other adenocarcinomas. The origin of fibrous mesothelioma is submesothelial mesenchymal cells, not mesothelial cells.